See if I can do this right. Hey, look at that. I figured it out. All right. So once again, welcome everybody. Welcome to our Risk Adjustment 101 high-level overview of risk adjustment. Any questions that you have during the presentation? We do have a question and answer section. You're welcome to put your questions in there. And Mimi, my favorite co-pilot, will get them answered for you. Just a couple of housekeeping items. Screenshots or snips, please refrain from taking any screenshots or snips as our information or content is proprietary information. So as always, no flash photography during the presentation. So we're going to get this plane take off. So make sure your seatbelts are fastened. Make sure your chairs are in their fully upright locked positions. And here we go. All right, so here we go. Let's step through one of our housekeeping items here. This is our disclaimer, just letting you know that this presentation is for educational purposes only. It is never intended to override your opinion or standard of care. Remember, it's only about ethical and accurate reporting of those conditions of that what are true to your patients. All right, so what's on the docket for tonight? Well, cat's already out of the bag, right? Risk adjustment methodology. We're going to be talking about that value-based care model, giving you a brief overview of it. And then I'm going to throw in, just for fun, a few chart examples as well to let you show, to kind of demonstrate, how the model works and, how you can work for it. Remember, the value-based care model isn't doing anything extra. Unfortunately, we get that question a lot. Well, it's doing a lot of extra work. It really isn't. All it is being specific with your diagnoses, right? And making sure you have valid treatment plans for them. So let's get into it. So value-based care. The focus really is on the cost of care, and patient outcomes is probably one of the main drivers of value-based care. Right. So if that's where the focus lies, then how is the risk burden? Because you've all heard that before. What's the risk score? RAF, risk adjustment factor. How is that quantified? Well, enter risk adjustment coding, ladies and gentlemen. It's all about appropriately projecting the spend or funding for the patient. So how do we project the spend or funding for the patient? Anyone? Anyone know? Anyone know? Through your diagnosis codes. It's no secret. So what CMS was able to figure out with this model, with value-based care in general, is that specific conditions have a greater cost of care from others, and hence those specific conditions were chosen to be a part of the value-based care model. So there's no secret. It's all diagnosis driven. That's the secret of this model. Again, it's all diagnosis driven. It really has nothing to do with an E&M level. That's old school, right? Let's kick it old school for a minute. That's fee for service coding. Fee for service coding is based upon an E&M level, right? And so what that determines how complex your patients are. Is it a 99213 214 215? That's fee for service. You get to a 5, well, your patient's pretty complex. In value-based care, it's all about the specific diagnosis codes, right? Being specific, not just saying CKD unspecified, but saying, no, they have CKD stage 4. Or not just saying they have some type of heart arrhythmia. No, it's about saying, no, they have paroxysmal atrial fibrillation or they have diastolic congestive heart failure. That's what it's all about. And what it's not about, and we get this one a lot. Yeah, I'm going to be very specific here. It's about telling the clinical story of your patient. It's not about making your patient sicker. It's about showing CMS, showing the payers how complex your patients are. So just like in those examples before, if you're just, giving us, oh, well, they have CKD unspecified, you're not staging it, you're not being very specific. You're not showing the true complexity of the patient. So if you're doing that, CMS may be seeing, this lovely young lady here holding a bottle of water, maybe just got done with a 3 or 4 mile walk. She's got her Apple Watch on, tracking her steps. She looks pretty healthy, but she may not be. This could actually be the reality. You know, is your patient dependent upon oxygen? Do they have COPD? Do they have chronic respiratory failure? What other conditions do they have? Remember, this diagnosis reporting model is all about telling the story of your patient. That's how that's how we show the complexity of your patient. And all of those diagnoses are relative to the projected spend of your patient. So again, what CMS was able to do, all those diagnoses that, cost the patient a lot of money and cost, to be cared for, like cancer, heart failure, AFib, things like that. Those cost a lot of money to be cared for, right? So that's why those specific, conditions were chosen for the model. So you want to make sure it's not about making the patient sicker. I'll say it again. It's about making sure you're reporting those conditions that are true to the patient. Be specific with your diagnosis coding, right? It's not a secret. With value-based care, you got to let the cat out of the bag. If they're on a specific medication, I know how it was way back in the day. If a patient had major depressive disorder, and I was told, well, that's really no one's business. That's why they're on this medication. No, in value-based care, we need to know. You need to make sure that you're getting credit for your work, number one. Number two, you need to really show the true complexity of your patient. And the only way you're going to be able to do that in this model with value-based care is through your diagnoses. Okay, let me get off my soapbox here. All right, so we kind of said the magic word about value-based care. We talked about risk adjustment. What is a risk adjustment factor, right? RAF score, things like that. So how do we build the RAF score? Well, it makes up obviously all of these components that you see here. The demographics, this is all done on the back end, right? Picture playing Monopoly, and every time you pass go, you collect $200, right? That's demographic. But with value-based care, everything is based on an annual basis, right? So that's kind of the secret with the value-based care model here. What you're doing is you're projecting how much is it going to cost to care for my patient in the upcoming year. So diagnoses captured this year in 2025, or what's been captured this year in 2025, go on to determine how much it's going to cost to care for your patient in 2026. So demographics a big part of it, but this is done for you on the back end by CMS. So is your patient a male or a female? How old are they? Where do they live? Did they age into Medicare like when they turn 65, or did they become eligible due to a disability? All those things are factored in on the back end. You don't have to worry about that, which is good. The diagnosis codes, which I've been lecturing you about, and hopefully it doesn't sound like a lecture. This is where you guys live. This is the key component here. It's those specific HCC codes, or those hierarchical conditional category codes. All of those diagnosis codes have what's called a RAF value, or a risk adjustment factor, right? And that, determines the score or the complexity of the patient. And then you have these other things, disease interactions, right? So when you have a combination of diseases, I'll give you an example. So if your patient has diabetes and heart failure, CMS adds what's called the disease interaction RAF value, right? So that's added to the score. So that's why we always ask, you report all conditions, whether they're being managed by a specialist or yourself. So if they're seeing an oncologist, they're seeing a pulmonologist, rheumatologist, etc. You want to make sure you're reporting those conditions as well. Because remember, think of yourself as a manager of all your patient's chronic conditions. So you want to make sure you have your finger on the pulse of the patient. Who are they seeing for those specialties? What medications are they taking, et cetera? And you want to make sure you're reporting those conditions at least once a year. And then we have a thing what's called the payment condition count. So when you have five different diagnoses from five different HCC categories, CMS is going to add what's called a payment condition count. So that is also done on the back end. So even more incentive to report all of your patient's conditions, even if they're being managed by a specialty. And then that would give you your raw risk score, or your raw RAF score, as we call it. Now, I mentioned fee for service, right? So the average fee for service RAF score for a patient is 1.0. And this will, I'll be able to paint a better picture for you on the next slide, but just remember that 1.0. That's the average score. And that's taking into consideration all of these, right? Demographic, what codes are reported, disease interaction, payment condition count, everything. It may seem like a lot, but when you see the next slide, it really isn't. It's very easy. And, most times, what Mimi and I see is that, most conditions are actually underreported. So yeah, anything less than a one, which is going to indicate a healthier patient. Anything more than one is going to indicate it says sicker here, but really more complex. Remember the young lady with the water bottle and the gentleman to the right of her with the oxygen mask? That's what you're trying to portray with these diagnosis codes, right? You're not making them sicker. You're trying to show the complexity of the patient. Just remember that. And then this is what we call, you remember, the risk score is calculated every year. Remember, all your diagnoses being captured this year goes on to determine the spend for the patient next year. So for 2026. So we like to think of that as filling the glass of water, right? So every year, so come December 31st, there it is. The glass gets empty, and then CMS, or then you, the provider, you need to fill that glass up with all those diagnosis codes that make up the true complexity of your patient. And I know it sounds silly, even if they have amputations or things like that, you still want to make sure that you are reporting those conditions year after year. Amputations, ostomies, right? Every year. All right, so I lied to you. This isn't the slide I was talking about. It's actually the next one after that, but this one's important as well. So remember, there's only specific provider types that can actually report risk adjustment data, right? So your physicians, obviously your MDs, your DOs, your PAs, your nurse practitioners, okay? Family practice, internal medicine. But remember, an RN is not an acceptable provider type for risk adjustment. You have to be a specialty on there, just like the list that I mentioned there. So if an RN is reporting, your conditions, it's not going to count. There are specific rules, and that's just like there are rules with everything. And these are the rules of risk adjustment, not Frank's rules. No, they're CMS's rules. And take a look at the acceptable outpay or settings as far as for um, when those diagnosis codes, those HCCs, can be reported. So as you can see, you have the acceptables here and then the unacceptable. So obviously the acceptables are going to, include, hospitals, any specialists, when they're coming in to see their primary. But take a look at the unacceptables, right? If your patient's in a sniff, or if they're going to a dialysis facility and they're on end stage renal disease, right? And you're thinking, oh, well, the dialysis facility, that'll count for the patient's RAF. No, it won't. Or any imaging centers, any labs, or DME. DME is a big one as well. Say your patient has an amputation and they're going to DME to get a new prosthetic. And you're thinking, oh, well, the DME is going to submit that claim with with the correct diagnosis code, so they'll capture it. No, doesn't count. Doesn't count. So again, picture yourself as a manager of all your patients' chronic conditions, report all those conditions that are true to your patient. Okay, I lied again. It's actually not this slide, it's the next slide. This is just kind of a high level overview of what we just finished talking about, right? For the Part C model. That's the value-based care one we're talking about. And then again, we call it predictive modeling or we call it additive modeling. So predictive modeling means if your patient has the same conditions over and over again, that's why I said before, it's very important. If your patient has that left below knee amputation, they have diabetes, they have COPD, and they have heart failure, it's important to report all of those conditions year after year. That's what we call predictive modeling. We can predict the spend. We know how much it's going to cost to care for that patient in the upcoming year. Where the additive comes in, and obviously as your patients get older, other things happen. Oh no, maybe they get cancer, God forbid, or maybe they get rheumatoid arthritis, COPD, etc. That's where the additive model comes in. So now you're adding a new model. So now you're going to be increasing the spend of how much it's going to cost to care for your patient, and you're going to be doing that year after year, as long as those conditions are still valid. Okay. This was a slide I was talking about that hopefully puts it in perspective. Okay, so let's say, for example, your patient comes in for their annual wellness visit, right? The AWV, it's just a list of questions, right? Hey, are you still seeing your cardiologist? Are you still seeing your pulmonologist? Or do you have any tripping hazards? Things like that. I'm going to repeat 3 words, and you repeat them back to me in a few minutes, etc. Right? That's the best time to report. That's the best time to pick up all your patient's chronic conditions, right? During that visit. Unfortunately for this one, they didn't do that. So what happened was the patient came in, you just put that zoo code down there, Z00.00, and you went through the list of questions and you called it a day. So this is that patient's risk score, 0.624, right? That's all that risk score is a demographic, and this is how, and this is why. So it's an 85-year-old female. So 85-year-old who aged into Medicare, 0.624. So no other chronic conditions were reported, but we know because remember, with value-based care in this model, we can predict how much it's going to cost to care for the patient. So last year, the patient cost $22,000. But with only reporting demographic, right now the spend is about 6,800 bucks. So we're in the hole right now for this patient for 15 grand. All right, now they come back and okay, we do a little better job reporting. So again, you know, the score gets added 0.790, but look what we captured. So we got diabetes without complications, we got a UTI, we got CKD unspecified. We got an open wound of the calf, a current smoker, and a chronic cough. All right, we did a little better, right? It's better. More conditions were captured. We're getting the complexity of the patient, but the score is still kind of low. And look at the spend, what you're spending right now as compared to the actual cost. We're still in a deficit. How can we improve? Is there a magic formula? What's the secret of value-based care? Let me hear it. Yeah, I heard it. Diagnosis coding to the highest level of specificity. And as Emerald would say, let's kick it up a notch. Bam, look at that. So now the diabetes has turned into diabetes with CKD stage 3B instead of unspecified. Now they have diabetes with peripheral arterial disease, and now we have a skin ulcer. Much better than a calf wound, right? Yep, got an ulcer on the right calf. Now instead of a current or a chronic cough, we have a smoker's cough. Makes sense, right? They're a current smoker. They have smoker's cough. And look at that. We also have that history of below knee amputation. So now with reporting all those conditions, spend goes up to over 27 grand when the original patient cost was this at 22. Now we have what's called a surplus. I'm going to pause there. Anyone have any questions? If you do, you can raise your hand, come off mute, and you can ask a question because I've gone over a lot of information. Remember, it's about reporting what's true to the patient as specifically as we can, based upon the documentation. We just can't, be throwing these diagnoses out there left and right. We got to make sure we have that documentation to support. Oh, good. We have a question. Okay, I think you're off mute. You can ask your question.
Yeah, hi, this is Dr. Mikaris. I have a quick question. Now that the yearly annual visit is the main place where we put all the diagnosis, say we want to add that to the other visits, and patient has like 10 or 12 diagnoses. Should this visit just add them to the diagnosis code, or it has to be evaluated? Because sometimes, it's just a quick visit, and you want to, enlist that on the yearly, codes. Sometimes you think if I put them and I make like a level three, or it would be under coding, so you get into trouble from the other side. What do you think about that?
Well, that's a lot of information. Um, the short answer for that one is, sorry, I was trying to advance the slide. I think this will help. So even if you don't get all of those on the annual wellness visit, right, you still have the whole year to report those diagnosis codes, right, that the patient has. And looking at this specific guideline here on there, any condition, that coexists at the time, of the visit that requires, that affects care or management of your patient, you can report those other chronic conditions. So, the example I always use, say, you have a patient that has diabetes and COPD, and now they're coming in because they're sick, and it's like going, okay, well, maybe they have a URI or it's part of their COPD, and you're going to prescribe them some type of medicine for their cough or something of that nature. And in the back of in back of your mind, your medical decision making, you're thinking, well, I don't want their blood sugar to spike, so I'm going to give them something sugar free to try to calm that cough down. So right there you can report, you'd be able to report that diabetes. So if it comes into your medical decision making, you can report those other conditions. Or maybe you're prescribing an antibiotic and they're on COPD, they're on albuterol, or maybe they're taking prednisone or something of that nature. You want to make sure there's no, interactions with that. So if it's affecting your medical decision making on that day, with the other, with the acute visit or the acute, excuse me, conditions that they're coming in on, you can report those other conditions. And
Is it acceptable if I just say the same patient also has peripheral vascular disease, has an amputation, and actually we don't manage that? It's an old history, but you want to put it down. If I put it in the assessment, history of BK, history of peripheral vascular disease, or actually it is peripheral vascular disease still,
right.
and we just put stable, stable without evaluation, I don't think this should be a problem, right?
Well, you're halfway there. You still need to have a treatment plan. Remember when I said about acknowledging those conditions? So what medication would they be on for peripheral vascular disease? Or are they wearing like compression stockings, things like that? You need to
Yeah,
have, yeah. So
I got you. Yeah. Okay.
yeah. So
Yeah.
for the amputation, you'd be like, oh yeah, make yeah, baloney amputation, make sure your stump is, clean and dry. Your peripheral vascular disease, hey, maintain statin therapy, or you have to give a treatment plan just by saying stable or that the condition
Mhm.
is, at goal. What we need to know is, what's keeping that peripheral vascular disease stable or at goal. You don't have to write a novel, but you got to give us a little something to make sure that you're getting credit.
Got you. Got you. Okay. Thank you.
You're welcome. Good question. Okay, so the cat's out of the bag on this one, right? So just like we just talked about, and that was an excellent question, and it's amazing. Um, when you asked that question, I knew this was my next slide, and I'm like, okay, this is the perfect segue in. So yeah, so again, any condition, any acute visit, because we all know your patients only want to come in when they're sick. Sometimes they don't want to come in to see you when they're healthy. It's, no reflection of you. You guys are awesome people. I'll actually be up in New Jersey next week, actually. So I'm looking forward to that visit. But remember, if your patient, you got to drag them in there and they're coming in when they're sick, You can report those other chronic conditions if it's because obviously you're gonna think about it in your medical decision making. And like we always say, if you think it, you ink it. All right, this is a fun slide. So, how many diagnoses can you report during a visit? Is it four? Is it seven? Is it eight? Or is it 12? On one claim, you can report 12. Actually, you can report as many diagnoses as it takes to describe your patient. This claim form changed quite a few years ago. I can't remember the exact year, but the old days of just reporting four diagnoses are gone. All right, so it makes sure that your third party administrator, when you're submitting the claims, can accept at least 12 diagnosis codes. Make sure your EMR as well. You know, all your EMRs should be able to, submit, report at least 12 diagnosis codes. That'll help too. Oh, yeah. And the clearinghouses as well. A lot of times the clearinghouses will tell you, oh, no, you can't submit that many. I say bull, not the case. The problem is with a lot of the clearinghouses, they just didn't want to, like upgrade their software and things like that because it had been four diagnosis codes for so long. That is a thing of the past. They're living in the past. They're living in fantasy land. No, 12. You can report 12 or like I mentioned before, we have groups that are, submit like 18, 19, 20. But, again, that's all done on the back end depending upon, how your system is set up, your revenue cycle is set up, being able to send all those claims. But you got to make sure you can at least submit 12. And oh, thank you. Great point. It's not complete. It's non-compliant to not be able to accommodate at least 12 diagnosis code. That's a CMS rule. Got to be able to let you do that. All right. So for those of you who have been to our PEEP sessions, you know this. Those of you who haven't, shame on you. You're missing a fun show. But let me just give you the quick rundown of our color coding key example here. So anything we see in teal means that, based upon the information in the chart, that the condition, the diagnosis will validate. Anything we see in the gold means could be at risk for documentation. And what at risk for documentation would be if you just say something to the effect of, oh, yeah, it's, the condition is stable, continue regimen. What we want to know, just like the great question that I was asked before, we want to know what's keeping that condition stable or at goal. What's the regimen? Is it medication? Is it compression stocking? Is it yoga? Whatever the condition is. Or we have a query or a missed opportunity, right? Where you kind of did the hard work in the chart, but you just kind of didn't choose the most specific diagnosis code. Or, you had a missed opportunity where maybe the patient came in on a sick visit and it went into your medical decision making, but you didn't report it. And then we have red, the big Family Feud red X, or if you're a Marvel movie fan like me, the Wakanda Forever sign. Anything you see in red means that it wouldn't validate. Okay. So let's get to our first example here. Apologies for the typo here. We have an 80-year-old man boy. Sorry. Apologies on that. Okay, we have an 80-year-old man coming in for a sick visit. As you can see, fever started a couple of days ago, right? Strep test was given. He's got a sore throat. Look in the past medical history. He's got type 1 diabetes. Hint, hint, wink, wink. Look in the physical exam, too. Positive for nasal congestion, red throat on exam, mild wheeze heard in lungs. That's great. This is what we like to call the consistency, throughout the note. If you're saying it up in the subjective, right, in your HPI, about the complaints on there, best practice is we want to see that in the physical exam as well. All right, so this patient was reported with an upper respiratory infection, but we had a missed opportunity here. They did all the hard work. They're going to prescribe a sugar-free cough suppressant and give free samples of sugar-free throat lozenges for a sore throat and monitor your blood sugar closely. So again, comes into your medical decision making. You can report those conditions. So say they missed their annual wellness visit. Now they're coming in when they're sick. I would report all those conditions that are true to the patient, especially because you know they're going to affect how you're going to treat this condition. You're going to be thinking about a lot of things. All right, I'm going to prescribe, they just have a URI. I'm going to prescribe this, or maybe it was something else and I need to prescribe an antibiotic, but oh, they have this condition, they have that condition. If I'm thinking about it, I'm inking it, right? If you think it, you ink it. It goes into your medical decision making, put it down on your chart. Remember, it's like that math teacher that made you turn in that piece of scratch paper. Show your work, get credit. Just don't put the answer down. Show your work. Show CMS, show the payers all the additional critical thinking that you had to do to come up for that upper respiratory infection. Show your work. Add that diabetes on there. Went into your medical decision making, put it on paper. Okay, now that we've gotten rid of the 80-year-old man boy, let's go to our next example. And this is an annual wellness visit. This is a really great example on here. And just remember, as you're taking a glimpse of this, you're not writing a whole dissertation, on the chronic conditions. You're just giving me short, little, succinct treatment plans. And this is a really great use of the HPI. Again, everyone has a different style. Do you have to list them all out here? No, you don't. You don't, but this provider did. But we can definitely follow the path. But look at the treatment plans on here. Diabetes with neuropathy, well controlled on the two medications, obviously, for the glimepiride and the gabapentin, because you're covering both the neuropathy and the diabetes, and then hyperlipidemia, well managed on a statin. I mean, you don't have to, sometimes dot phrases can, really confuse you. If you can just give us a few, just give us a quick little phrase on how the condition's doing and then what the treatment plan is, right? Just like on all these. The AFib, well controlled on Eliquis. Need I say more? Do you have to say anything more? No, you really don't. Continue taking, alpurinol for the gout here. So yeah, this is a really nice example. Make the most of those annual wellness visits if you can. And, if you can't, remember, you have the whole year to report those conditions. It's a marathon, not a sprint. All right. So here's our next example. So we have a 12-year-old patient coming in for a sick visit. Right? Patient doesn't have a fever, right? It's been coughing, blowing her nose for the past week, experiencing tightness in her chest. They do mention up here has prednisone to control her persistent asthma, but hasn't been taking it. So once again, we have that missed opportunity to report that asthma, right? And I love, the supporting documentation in the physical exam. It's very crucial on there. All right, here's a fun one. There's actually three conditions here that were missed. Give you a hint. No, maybe I won't. No, I will. I'm in a good mood. Tomorrow's Halloween. So, one of the diagnoses that were missed was dependent on oxygen, the Z9981, but it's not going to show up here when I click the button. What are the other two conditions that were missed? So, remember, coming in with flu-like symptoms, having a cough, flu test was given. It resulted in being positive for influenza type A. We do have the oxygen in place. See if you can figure it out. What was missing here? We got the influenza type A, right? Continue to use your albuterol for COPD and make sure you are wearing your oxygen 24/7. I know as a coder, when I hear someone has oxygen 24/7, I said, woo, there's a missed opportunity. Yeah, so obviously the first missed opportunity was for the COPD, and then the second missed opportunity was have chronic respiratory failure. How many of you have patients that are dependent on oxygen 24/7? If you are, this is the code you should be using, that J9611. Is it an HCC code? Of course. But more importantly, it's describing the complexity of your patient, right? And plus that they're dependent on the oxygen using that Z code, the Z9981. So again, kind of reflecting back or reframing, value-based care is not about making your patient sicker. It's showing the complexity of your patient. It's showing that blueprint. And without COPD and chronic respiratory failure and just reporting, influenza and not reporting anything else, remember that patient's going to be in a deficit, right? When you're looking at the total spend for the patient, because we know the total spend is going to be so much more to be cared for. But if all you're reporting is, one out of the three conditions, you know, that patient's going to suffer because they don't have enough money. They don't have the funding that's going to be sufficient to be cared for them. So it's a win-win situation. When you report all those conditions that are true to the patient, it's not only winning for the patient, because a lot of the things that the patient gets through value-based care, it's like silver sneakers was derived through, value-based care. Um, like when they're able to give out heart monitors, blood pressure monitors, what are those things to, track their glucose monitoring, things like that. Those are things that are like the benefit of value-based care. Those are, those are what's helped funding uh, for your patients, in value-based care. So, there are positives for your patient, and there, obviously there are monetary, positivity for you, the providers as well. How much you get, I don't know. That's where your actuarial comes in, and that's math. And, Mimi and I don't do that type of math, but, we can do the math for you as far as figure that out. All right. So here's the good part about reporting when your patient has diabetes with multiple complications. I'm always asked, so how many complications of diabetes do I need to report? And the answer is you report as many complications that are true to your patient. But here's the good part about that. When you're reporting diabetes, remember, you're only going to need one treatment plan for your diabetes. Right. So as you're looking at the diabetes with multiple complications, again, really nicely done on here. It's an ulcer, right? They have PVD, right? Managed on a statin and aspirin. Again, you're really not, you don't have to say too much about it. Again, you're acknowledging those conditions. They may be managed by cardiology. And you can say that, hey, managed by cardiology, continue taking your statin as directed. Boom, you're done. You've acknowledged that condition. You just want to make sure you get credit for it and that you report it. But I digress on here. So when you're reporting multiple complications of diabetes, the good part is you only need one treatment plan for the diabetes. So look at the diabetes with peripheral vascular disease. So we have our treatment plan for the diabetes here. Where's the treatment plan for the PVD? It's up here. So the HPI, the physical exam, and your assessment and plan sections are what we like to call your three safe spaces for that supporting documentation. And this is all dependent on how you like to do your chart notes, how you like to do your documentation. This provider, again, just likes to kind of bullet everything out in HPI. That's great. So again, you just need one treatment plan for the diabetes, and we got it. We got it right here. Now we have diabetic ulcer, right? So we have the diabetes code and we have the ulcer code. No reason to repeat the diabetes diagnosis or treatment plan, excuse me. We have that here. So just focus on the manifestation, focus on the treatment plan for the ulcer, and there it is. Same thing here. Your diabetes with CKD stage 4. Do we need to repeat the treatment plan for the diabetes? No. Just give us a treatment plan for the CKD4. So that's the good part. When you do have multiple complications of diabetes, you don't have to repeat yourself. Just give us one treatment plan for the diabetes, and then just focus on the treatment plans for the manifestation of the diabetes. All right. My favorite provider. You okay? Ask your question.
I'm sorry, I pressed by mistake. I apologize.
Oh, no problem. All right. And again, we have that consistency through the no, and we actually also have the treatment plan up here. So we have the treatment plan in two different spots. But remember, you don't get extra credit. I wish you could, but you don't. But again, we have that consistency. Right ulcer. It's managed by podiatry, right? And we called out the ulcer in the review of systems in the physical exam as well. And then we got that treatment plan for it. Okay, so let's wrap this up. So we always like to talk about the problem address guideline because there are many rules that we have to follow, right? We have ICD-10 rules. We have RADV rules, RADV audit guidelines, risk adjustment, data validation. We have CMS rules, and then we have CPT rules. Yep, CPT, that's where your E&M codes come from, the current procedural terminology. But what they say is that with the problem addressed, the problem is not considered addressed without additional care coordination. So what does that mean? And our good doctor actually answered this question when he asked a question. If we just put stable, that's okay, right? No, unfortunately, it doesn't meet the problem address guideline. Okay, you're giving me a stable, but again, we need to know what's keeping it stable. And this actually comes from your good friends from the American Medical Association, right? This is directly from the AMA. So what they want to know is they want to have that additional care coordination. So stable or just follows a urology. Well, that's not enough. Like in this example for the prostate cancer, we want to know what that additional care coordination is, what that treatment plan is. Going back to my good friend who mentioned about the peripheral vascular disease, right? No, just don't say stable. Hey, continue statin therapy. Continue wearing your compression stockings. Yeah, that is a treatment plan. That's what additional care coordination is. Okay. And I think I just went over this on the last chart, but we'll say it again. This is where we like to say where we can hear the provider's active voice. So again, your HPI, we can pull that supporting documentation, or if you want to bullet out your diagnoses and with your treatment plans up there, that's great. You can do that. Just make sure, ladies and gentlemen, that you drop those diagnoses in the assessment and plan section. Where else can we hear your provider's voice? Physical exam. So remember, if you're telling us that yeah they have an ulcer, I changed the bandages, or they're seeing things like that. We want to see an ulcer, in the physical exam, or if they have a below knee amputation, we want to document that. Put that they're missing a limb in the physical exam, or if their asthma or COPD is exacerbating. Put that in the physical exam. We want to see that as well. We want to have that consistency through the note. And then, of course, the bread and butter, your assessment and plan. Make sure again, you're diagnosing the highest level of specificity and you have a treatment plan for it. And again, that's where your other supporting documentation can come in. And remember, just so you know, this is coming directly from CMS. And I don't mean to pick on you. I know you said, when you're reporting conditions from, a specialty, just saying that everything is, well managed or it's stable. That's half the battle. But remember, CMS wants to know what's the medical plan of care. That's where I always like to say you can just acknowledge those conditions. Hey, yeah, the patient's rheumatoid arthritis as well. It's being monitored by rheumatology. Continue taking, your methotrexate. Or you don't even have to say it's being monitored by rheumatology. You can just say, hey, continue taking methotrexate and let us know how it's doing in the office today, right? Let us know the status of that condition if you know. But again, coming from CMS, reason why the patient's coming in, etc. And this is Lumeris's rubric here, right? So we call it DSP, diagnosis status plan. And I've already been, beating a dead horse as far as diagnosing to the highest level of specificity, but it's important. Remember, we're not making the patient sicker. We're showing the patient's true complexity. You have to think of it that way. Because if you don't, remember, you're shorting their funding and you're also shorting yourself. And when it comes to value-based care, if you get my drift there, um, let us know how the condition is doing, if it's known, how are they progressing, right? Sometimes you're not going to know. Right. If you haven't drawn labs in a while, your hypercholesterolemia, you don't know. You don't have X-ray vision like Superman does. I'd rather not have you leave a status on there and just give us a plan. Hey, continue taking statin. We'll follow up with labs. We're going to refer you to labs. Again, probably the most important things are obviously your diagnosis and your plan, and obviously, and the status is up there as well. Again, all you're trying to do is just tell a really short story, or as I like to say, just give us the Cliff Notes version. You don't need to say too much. You just need to say enough. What I like to say is sometimes less is more when it comes to your treatment plans. All right. Well, that's a wrap for tonight. I don't know if you've ever taken part of our PEEP sessions, a provider engagement and education program. But this is what we've done for this year in 2025. And yes, I did minor in film in college, so I like to make the PEEP titles fun and I like to do movie quotes during it. So yeah, we had a lot of fun with this one. 2026, we're still in the process of creating, but if you are interested in, riding out the last few, you can reach out to your pop health manager. They can get you the sign up for it. And yeah, you get a CME for attending the live ones. And, or if you watch it on demand, you also get a CME and you get a CME and you get a CME. It's good stuff. Learn a lot and you can ask questions during it, etc. All right. Talk about a fire hydrant full of information, right, on value-based care. Hopefully you found it interesting, and hopefully you learned a few things tonight as well. As I mentioned, I will be up in the New Jersey area next week. Can't wait to bring home some bagels down here to Jacksonville, Florida. Looking forward to the pizza, that's for sure. But any other questions that you have? I know the pop health managers have to get a hold of me, but yeah, remember this email. So any questions that you do have, you can reach me at fgarip@lumeris.com. I'll be happy to answer any questions that you have. Otherwise, that's a wrap for tonight. We do have a few minutes. I'd be happy to answer any questions that anyone has. All you have to do is raise your hand. I'll give it a minute. I'll go on mute and I'll take a sip of water. But also remember too that this presentation was being recorded. So if any of your colleagues did miss it, we're going to figure out a way to get it on a platform for you. I think one of our colleagues actually has like a YouTube platform as well for some of the pod meetings that were done by HMH. So I'll give it a minute. Want to say a special shout out. Ah, I see you. Special shout out. Thanks for joining, Dr. Pappas. I'm glad you were able to attend. But let me give it a minute, see if anyone wants to raise their hand. Otherwise, I will set you guys free. All right. Well, I want to respect your time. I gave it a minute. I don't see any other questions. Again, fgrip@lumeris.com should you have any other questions. And remember, this session was recorded. So tell your friends if they missed it. we'll let you know as far as what platform that's going to be on. Otherwise, I'm going to give you 5 minutes back to your night. I appreciate the questions. I appreciate your attendance. And have a great Thursday, but have a better Friday and have a much better weekend. Thanks so much. We'll catch you next time.